look fantastic.
Okay.
All right, begin to do it.
Thank you, Mr. Speaker, for recognizing me and for my photogenicness. With that being said, let's get into this resolution. We're talking about terminally ill patients, and Julie and I would like to propose a very specific model. In particular, we're going to say that the United States government, through the funds of Medicaid, should no longer cover the cost of dialysis treatment for end-stage renal failure. And for clarity's sake, this refers to stage 4 renal failure, after which point a patient is no longer eligible for a transplant. Now, I've got 3 things I'd like to talk about. First of all, the historical reasons for the law and why they're no longer applicable. Second of all, the point of Medicaid and how it's not met by this dialysis treatment. And third, the harms that this particular allocation of resources, scarce as they are in Medicaid. My partner Julia is going to come up and talk about the further effects on the medical community that this, and medical practices that this allocation of resources has. That being said, let's talk about the historical reasons for the law. As you may or may not know, the Medicaid decided in the 70s to pick up the tab for all medical expenses required for end-stage renal failure across the board, regardless of income, class, creed, what have you. This was because the practice of dialysis has recently been developed, and it was seen as a breakthrough miracle science that we could keep people alive despite the fact that their kidneys had completely gone kaput. We just landed on the moon. We thought, technology is really hot right now. As a developed country, we cannot afford to let these people just wallow away and die when we have the medical resources to protect them. However, over the past couple of decades, we've seen a burgeoning community of people who are suffering from end-stage renal failure to the point where the federal government can no longer bear this cost. Right now, this lobbying practice of wheeling dialysis patients onto the floor of Congress and having them say, please pay for me or I'm going to die, no longer makes sense when we have hundreds and millions of underprivileged people in our society, no thank you, who are actually dying from all sorts of different diseases right now that cannot be paid for because huge, vast sums, millions and millions of dollars are being poured into an ineffectual practice. That being said, let's talk about what Medicaid is actually for. Now, first of all, it's like, oh yes, before I go.
You say it's ineffectual, but it does keep people alive longer, right?
Yeah, I'm going to get to that in my third point, and then you can see how well it actually provides for these people. So, what's the point of Medicaid? We'd like to tell you on opening proposition that Medicaid is intended to provide medical care, obviously, for people who are otherwise unable to deal with it themselves. The vast majority of people people in Medicaid are going to be largely unemployed, perhaps elderly. This actually applies fairly well to the people with renal failure because renal failure tends to hit people late in life, and and due to the fact that they have renal failure and dialysis required, they can no longer work. So they're necessarily unemployed by the time that they need to go into onto dialysis. So we see that 95% of the applicants for dialysis are currently being met, and the government is completely picking up the tab. What does this do? What are the implications for Medicaid? Right now, we're paying huge amounts for what was initially, and it continues to be, essentially a technology that's pushing the borders of medical science. Right now, we cannot actually keep people alive. We cannot actually bring people back to the same quality of life that they were at before renal toxicity hit. What we've got is actually terminally ill patients where we're using the best technology we have, and it's still not good enough. On the other hand, what could we be paying for with Medicaid? What is the actual purpose of Medicaid? Right now, we need this Medicaid to pay for hospital visits, emergency room visits for people who cannot pay for these things themselves, operations. In fact, 30% of the homeless people in America are currently suffering from schizophrenia, something that Medicaid should be taking care of, but currently doesn't have the resources to do.
Do you think it's morally acceptable for rich people with private health insurance to pay for this practice? And if so, why is it immoral or unacceptable for the government to pay for it for people?
The problem with what we've got currently in the status quo is that the government is paying for everybody regardless of how rich or poor they are. So even if you could pay for the dialysis treatment yourself, the government will pick up the tab simply because we've got an ineffectual law in place. So they're overburdening themselves hugely at the point in which they're willing to pay for this for people who could pay for it themselves. Furthermore, dialysis is actually, once you're on the Medicaid system, because you're on dialysis, the federal government will in fact pick up the tab for all your external medical expenses as well, meaning that somebody who's got renal toxicity will also have the government pay for everything from a broken arm to an emergency room visit, anything at all, is covered by Medicaid, even if it wouldn't ordinarily be so. So that being said, how we can now see that we're not actually fulfilling the role of Medicaid through this dialysis program. Let's see exactly why it is that this particular allocation of resources is so ineffectual. Basically, what we've got here is a rather blunt instrument trying to solve a biological failure in an ineffectual manner. What we see, okay, dialysis patients are given this questionnaire by social workers where they are essentially asked to say, how much of your life would you be willing to give up if you could go back to, like, say you're 50, life expectancy is 80, how much of your life would you be willing to give up if you could go back to a perfect quality of life before renal failure? They say, I would give up 60% of my life to get off of dialysis and just go back to being a normal person. This is on par with terminally ill cancer patients going through chemotherapy. So even the best of what dialysis can provide for people is still on par with the most terminally ill cancer patient. So what we've got right now is a hugely ineffectual system that requires people to go in for dialysis treatment 3 times a week for up to 4 hours each session, completely making it impossible for them to work and lead a normal lifestyle. It's a painful procedure that leaves people drained, unable to pursue. Yeah, can you guys quiet down a second? That leaves people unable to actually pursue a normal lifestyle because they're constantly going into dialysis clinics. Furthermore, it restricts the lifestyle choices of these people, keeps them basically unhappy, and doesn't actually achieve what was initially purported to be the purpose of of dialysis. Right now, we see that dialysis is extremely effective in acute renal toxicity, where people can go in, their kidneys are temporarily overloaded, they can be put on dialysis, after 3 or 4 weeks, they come out, they're perfectly fine. However, what dialysis is not effective at is keeping somebody alive for a long period of time and actually trying to restore them to their original quality of life. In this situation, we see that we're pouring hundreds of millions of dollars every year into an ineffectual program that this money could otherwise be used for the actual purpose of Medicaid, which is to promote the welfare of those disadvantaged people who cannot pay for themselves. Thank you very much. For these things, we're very proud of these.
I thank the gentleman, and I now call on Angela to begin the case for Princeton and the opposition.
Ladies and gentlemen, I'm a little bit confused by why this is sort of the model that first prop set up. Because it seems to me that this is a situation, that the sort of kidney dialysis situation is a situation in which there's not scarce resource allocation, but inefficient resource allocation, where the government is paying for too many people who can actually afford it themselves or through HMOs. I don't think that's actually very pertinent to the resolution. I think what we should be talking about today is whether or not the U.S. government Medicaid should actually cover dialysis for stage 4 renal failure, as they said, for people who aren't able to afford it, period. Because they're planning to actually get rid of this for all people in general, right? Even the really, really poor people who are on stage 4 renal failure, who have no other means to do so. We think that it's perfectly acceptable for side opposition to say people who can pay for it themselves through private HMOs or private healthcare should be able to do so. However, we would also say that on our side of the house, individuals who couldn't pay for it because they were too poor to do so should continue to be covered by Medicaid. I think that's the pertinent analysis. So with that said, I want to get to some quick points of rebuttal and then move on to our independent case for itself and talk about that later. So first, I want to look at the 2 big ideas coming out of side of opposition today. First, they go through this long history of Medicaid and renal failure and all that stuff, right? Basically, they say it just costs a lot of money to be normal, right? And we think that that's fine. A lot of things cost a lot of money, but that's not actually the argument. They say renal failure tends to hit people who are poor, old, and can't work, right? This is exactly what we're talking about. People who have no other means to actually live their lives must have the ability to actually live out their last days in not suffering or whatever. So if they're actually suffering, that they would be able to choose to actually do so rather than being forced to die. We think that's really, really bad that the government is actually just forcing them to die by saying we're just going to withdraw all funding for your dialysis altogether. When people ought to be able to choose so. Then they say, well, here, all this money could be paying for other things like emergency room visits and schizophrenia, of homeless people, right? First of all, the United States already has a law called EMTALA, which means that individuals or emergency rooms couldn't turn people away if they want to go into the emergency room. That's just true. So thank you, not right now. Furthermore, I don't think schizophrenia is a terminal illness, and they have to prove to you substantively why schizophrenia or homeless people, deserve more Medicaid than people who are on renal failure. I think that's just just saying that doesn't actually mean that's true, right? If in an ideal society, the government would fund
why this should be funded more than something else. Sure.
Okay, but at the point where it's proven that continued and consistent treatment of patients with schizophrenia actually allows them to work and to recover, whereas end-stage renal failure treatment dialysis doesn't, it very clearly
Sure, actually no, it doesn't, because what you have here is sort of like a value, okay, so that actually gets to the entire point of like what medicine is all about, right? I think when you go to the emergency room, the doctor doesn't say, I'll treat you because you're more likely to live, and I won't treat you because you're more likely to die. No, thank you, not right now, right? I think the government or the doctor has to make decisions based on, whether or not they can do all they can, not, what is most likely to succeed. We think that this is very, very bad. It creates perverse incentives for doctors if they're not going to treat the people who have worse diseases than people who have lighter diseases. No, thank you, not right now. Okay, the second argument they give is that there's this poll taken that 60% of these people decide that most of these people decide that they would give up 60% of their life to be healthy, right? That's actually not really an argument because most people would just say that, most terminally ill patients would just say that, period, right? That doesn't mean that people would actually, you haven't asked them the pertinent question, which is how much would you pay to stay alive? How much do you want your government to pay for you to stay alive, right? That's the actual argument that we're talking about here. So let's move into some substantive material. So basically what we're going to talk about today, I'm first going to talk about sort of how society allocates its resources and what a just society would do. Second of all, the definition of terminally ill and sort of its effects under their plan. And third of all, about suffering and impact. And Tim is going to talk about sort of the philosophy of healthcare and whether or not medicine is actually allocated. So the first argument I want to talk about is actually a very general one, but I think it's particularly pertinent here. And this is the idea of John Rawls's theory of ability. Right? Basically, we're evaluating how society ought to treat its people. And we on side opposition believe that how society treats the worst off is actually what a just society ought to do. It's actually determining how just a society is, right? We believe that a just society will maximize equality for all people, but also that a just society will allocate resources based on how it benefits the worst off. Because we human beings, thank you, before the fact that we know whether or not we're going to be born rich or born white or born genetically predisposed to cancer, ought to be able to be allocated resources not based on these things that we can't choose, but based on how much we're worth as an average human being, right? I think that in this situation, we clearly see that an individual can't just be left out of the system just because they happen to be genetically predisposed to a certain situation, or because of the fact that they happen to have kidney failure for no fault of their own, right? This is very, very important to consider insofar as these people have done nothing wrong and actually deserve what they have, deserve to have some sort of care for them. And insofar as it's totally, regardless of whether it's totally unfair to say because of the fact that you just happen to be healthy and happen to be rich, you'll be able to afford this. And if you happen to be poor and happen to be unhealthy, you wouldn't be able to afford this. This is the entire idea behind Medicaid. We don't see how this shouldn't apply to human analysis. The second argument is a very important one, which is what does terminally ill even mean, right? Okay, so I understand that in the current status quo, there's no real proof or no real cure for this disease or a lot of the other diseases that we're talking about in terms of terminal illness, right? However, as you can see, right, first of all, in last April, the United States District Court of Columbia actually approved expanded access for terminally ill patients, access to experimental drugs that are not approved by the FDA. Why do they do this? Because they see the possibility that some drugs could actually, the drugs that are not currently in the market could actually, solve these people's problems or at least alleviate their problems in the future, right? No, thank you, right? The realization here is that drug tests are often not performed on people with other genetic backgrounds, races, and stuff like that, and could work on certain people, right? So the fact is, the government is willing to allocate, funds and resources to actually give these people a chance to live, give them the ability to actually, start a new life, or at least, lend them their time on earth to be with their families or to do whatever they want to do, right? We think this is very, very important. And insofar as they're cutting off treatment altogether to these people don't have the ability to do so. The next argument I want to talk about is the last argument is about suffering. Right? So basically, I think this is particularly unfair in the United States because in a lot of districts in a lot of states in the United States, there's no legal right to euthanasia, especially assisted suicide, based on legal, religious, or moral. It's not a legal, religious, or moral option for a lot of people. Right? Basically, what you're doing here is actually forcing individuals to suffer for a very long time, insofar as they wouldn't be able to access a lot of these other kinds of drugs and stuff like that because you're just sentencing them to death. Right? On the reverse side of that, realize that these people, there are people who don't want to die because they want to stay alive for a long time. They want to fight the last battle, to look for new cures and to be able to be with their loved ones for a long time. Right? Insofar as the government is actually forcing people to die at the time the government thinks it's convenient, we think this is particularly unfair, and it is particularly unfair to these people because the duty is to provide care in times of suffering and to provide these people with the ability to actually do what they want in their lives. For all these reasons, we strongly
thank the lady for her remarks, and now I invite Julia to continue the debate from the side of the government.
Thanks, Mr. Speaker, for your recognition. I want to do a few points of refutation into Angela's speech and then go on to the points that the opening government has brought up, specifically the chilling effect on the medical community as a whole, which Benjamin promised to talk about. So the first thing I want to kind of respond to is how, Angela comes up here and she really just complains about the model. And she says that, listen, it isn't a scarce resource. I think it's fairly clear, Mr. Speaker, that when we're dealing with the allocation of money, especially in terms of Medicaid, which is a perennially underfunded program in the federal government, it's very clearly a scarce medical resource. We would also tell you that the equipment necessary for dialysis is limited. That's why you have extremely long waiting lines for patients to actually get into dialysis treatment centers and things like that. This topic is entirely resolution. I just wanted to talk about that first. So, a lot of the things that we hear out of Angela is, how costing money isn't an argument and people ought to be able to choose. We would tell you that people ought to be able to choose up until a point where their choices are necessarily detrimental to the choices of the other people in the country. They ought to be able to make those choices and spend that money up until the point where that money is being spent in entirely inefficient ways, in ways that have absolutely no potential of actually changing the outcomes of their life at all, which is what Benjamin and I are talking about on our side of the house. The second thing that we hear out of Angela is that really, the medical community shouldn't be able to differentiate between individuals who are suffering from more serious diseases and people who are suffering from less serious diseases. Recognize, Mr. Speaker, that when you go into the ER, you are triaged based on the severity of your disease, based on the severity of things like that. We would tell you that at the point where you do suffer from a terminal illness, after which there is no apparent hope for you under any sort of medical condition, be it experimental or not, which is what these end-stage renal failure patients are, they don't push you as high a priority. We feel that it's therefore entirely consistent for the Medicaid community to actually, reflect that as well. I want to move on to kind of the substantive points that opposition offer, because I don't think that they're actually, entirely that substantive. The first thing we hear out of Angela is that, you have to deal with the allocation within society's resources, and that we should deal with the big veil of ignorance. Excuse me. I think that, I have a few responses to this. The first thing I want to talk about is how the only benefit of dialysis to these patients is actually living longer with a horrible quality of life. Benjamin touches upon this in his point, and I think it's entirely clear. I don't know how many of us actually know patients who are in end-stage kidney failure, who are on repeated dialysis, but let me tell you, life is pretty crappy when we spend 12 hours a day at the dialysis center 6 days a week, not right now. I think that at the point at which society recognizes that, there isn't things, as much as it's really hurtful to say this, sometimes people are beyond the help of the government, they're beyond the help of the medical community, and then the point at which you recognize that and the point at which you're willing to accept that, you actually get more efficient and better allocation of resources within society, which allows you to further, to better impact the kind of the veil of ignorance kind of argument that Angela talked about, because you're able to better direct these scarce medical resources to individuals who can benefit them, benefit from them, who can have more productive lives in the future, which is not something that would apply to these terminally ill patients that we're talking about in this graph. Which brings me to the second point she talks about, the definition of terminal illness. I think it's really funny that she talks about experimental treatments and things like that, and how you're going to have some sort of shifting definition of terminal illness. Recognize, Mr. Speaker, that the definition of terminal illness for kidney failure patients hasn't changed in over 3 decades. I'm going to talk about that later, but I think that it is definitely an effect of the dialysis, the payment of dialysis for these patients. We think that at that point in time, you don't get the sort of experimental treatments that you do see in other diseases like cancer, you do see in other diseases like Alzheimer's and things like that. You don't get that sort of medical research, and so I don't think that might be at all. And the third and final thing she talks about really quickly is how we don't really allow people the choice of euthanasia, and so therefore we recognize that they shouldn't be allowed to choose to suffer. I think it's important to recognize that we allow, you have to make tough choices every day, and as hard as it is to look at, an end-stage kidney failure patient in the eye and say, we're not willing to pay for this, it's simply beyond what the government supports. We feel that that's something that the government does every single day. It does it within the Medicaid community as it is. It denies individuals, who make just below the amount, just over the amount of money that it takes to qualify for Medicaid. I'll take you in a second, Andrew. We see that this is entirely consistent, and we think that actually on our side of the house, by denying all of these patients who clearly have no have no chance of actually recovering. You're actually going to get better allocation of resources. Sure.
So you're right, Medicaid doesn't fund everything. Medicaid isn't perfect. It doesn't fund all poor people's diseases. Isn't that an argument for making Medicaid better, not denying
Right,
people
and I
treatment?
think that you definitely make Medicare better on our side of the house because you have more efficient allocation of resources. Because you do allow for, Medicaid to focus on diseases which will allow people to re-enter the workforce, which will allow them to actually lead productive lives, which isn't something that you see in end-stage renal failure, and it isn't something you see in end-stage renal failure ever. I think then I want to talk about my point, which is the chilling effects on the medical community as a whole, because that is a reason that we haven't seen this at all. I think at the point where you see where dialysis centers see government support as irreversible, where politicians see government support as irreversible, a lot of individuals have no reason to further research towards solving the issue of end-stage renal failure. We've seen no medical advances over the past decades towards dealing with end-stage renal failure. We haven't moved the timeline of death out at all for individuals who are diagnosed with this. Benjamin and I can tell you that that's due to, largely in fact, to the chilling effect that does occur. I think, when dialysis clinics know that they will be paid, and they kind of create a huge cottage industry about getting people into their clinics solely so that they can, get Medicaid benefits out of this, it doesn't solve for the free market. You're not getting that type of, impetus to actually create change within that. So I think this chilling effect on the medical community as a whole is necessarily detrimental to the kidney patients and also detrimental to the Medicaid program as a whole. And it's really antithetical to the point of Medicaid. They come up and they kind of poo-poo our reasons for talking about the historical reasons. But I think it's really important to understand that, at a time, this dialysis was seen as a cure. It was seen as being capable of actually treating people with end-stage renal failure. We see now that it is only a treatment delaying the inevitable. It doesn't do anything to improve quality of life. In fact, you get a fair number of people who actually come off of dialysis as soon as they're diagnosed with end-stage renal failure because they recognize, and their doctors recognize, that they will have no improvement in quality of life. At that point, the harms of this particular allocation of resources, because it doesn't do anything to actually better their lives, because it doesn't do anything to actually better medical research, and because it doesn't do anything to actually better the Medicare community as a whole, should be eliminated. We stand very proud of the proposition.
I thank the lady for her remarks, and now I call on Timothy to continue the case for the opposition and Princeton.
Thank you very much, ladies and gentlemen. What I want to do in this speech is pretty simple. First up, I'm going to address some of the rebuttal we got to Angela's 3 points about how society operates terminally ill and suffering, in addition to critiquing the model. Then I'm going to address the one new point that we got from the second speaker from the opening government today about this chilling effect. And then I want to add some of my own positive matter about the philosophy of healthcare and how this notion about how society wants you to get back to the workforce, how it's somehow about restoring your original capacity rather than alleviating suffering is completely misguided and actually not how healthcare systems operate in the United States or really any civilized country. With that said, let's first get into this rebuttal. I think there are 4 areas to look at here. First, the model, and then the 3 points that Angela gave. First, with regards to the model, I think we just basically, I think they basically just got confused here and thought that our critique was actually just, we should give money to everyone or that it's limited equipment. I think the real point here was that we should just have this means test that Angela talked about. I think the reason for it is twofold. First, if you think this round out to be decided on, distributing scarce resources or making sure that the healthcare system functions as efficiently as possible, I think to that extent we can get a lot of the rich people, a lot of people who can actually pay for this procedure off the medications. I think to that extent we get lower costs. More than that, though, I think it's just more basically a social welfare issue. I think it's about assuring in this country that people, as they say with Medicaid, their healthcare, the condition of their healthcare, as long as it's not super revolutionary, shouldn't depend on your income, shouldn't depend on whether you're born into a rich or poor family. And I think this is especially pronounced insofar as diabetes and other illnesses like that tend to fall harder on the poor. People like that who have higher rates of obesity. I think given the fact that we have obesity and stuff like this, it's especially unfair. That said, though, what did we hear in response to our 3 arguments about how society operates, terminally ill and suffering? Well, with regards to how society operates, we hear basically this sort of philosophy. Well, your choices can be detrimental to other people. When you make a bad choice or a detrimental choice that infringes on the rights of other people, then you ought to be curtailed. You ought to be curtailed in the rights. Okay, I grant that this analysis works when it comes to punching people. We've all heard the argument about your right stopping at the point where my fist enters your face and stuff like that. However, they don't actually tell us why this applies to, the right to live. I think it's very telling on the fact that they're trying to paint, living as a choice. They're trying to paint the idea that somehow my right to live, my right to life in the United States of America ought to be weighed on an equal or lower level than the first speaker's ability to have an extra 2 cents on his tax bill. Oh, sure, thanks.
So what they're actually weighing against is the right for other people to live. You're choosing one expensive life over many less expensive lives. It's the difference between one life and many.
So listen, I think we've heard this point corrected once on second opposition already. I think insofar as we've already committed ourselves to a welfare state to some extent in the United States of America, I think we've accepted the philosophy that I'll expound later, that it's unacceptable for people to have suffering in the United States, that we need to take as many steps as possible, that we need to do that. And I think to that extent, we are saying it's unacceptable for people to live in these sort of horrible conditions. That said, though, what's the next area of analysis that Angela gives you? She talks about how the definition of terminally ill is sort of, vague at times. She gives you this U.S. district court case, showing that oftentimes the government wants to give people as many chances as possible to live. That further, by the way, repeats this POI that we just got. The response we get is, honestly, I think very surprisingly pessimistic. They say, there's no hope for you. You have to eventually give up. You have to eventually, say, because people actually are terminally ill. They say that the definition of terminal illness has been stable. I think the important thing to look at here is oftentimes when you have these treatments going on for stage 4 renal dialysis, I think people may actually oftentimes be incentivized to work on them. I know they said stuff against this. I'll get to this. You're angry right now, Paris. I'll get to this when you actually start addressing your positive matter. I think the point here, though, is at the point where these treatments are actually things that people are working on, where scientists may actually be working on how to treat people for stage 4 renal dialysis. You're going to see these experimental drugs that Angela talks about in the U.S. District Court case. And I think if we look at the history of other illnesses, this is particularly telling, because many times dramatic leaps forward in medicine have been made for illnesses for which people previously thought there was no sort of hope out. Now, thank you. Look at the development of ACT in the early 1990s. Look more so at the case of David Ho, the research scientist who invented AIDS cocktails in 1994, 1995. Both are tremendous discoveries that otherwise cured what other people call the gay cancer. Disease that other people thought was previous to that completely uncurable. I think to that extent we have to say that you should allow people to continue getting this in the hope that experimental drugs will be spurred. Thanks. The final thing we talk about is this issue of suffering. They again, in response, people have to make tough choices. Listen, I think if tough choices are going to be made, I think it ought to be on the part of patients who are already receiving this renal for dialysis. I think we ought to, give them the dialysis in the base state because we think suffering is unacceptable. But if at the end of the day they actually think and he actually buys from the analysis from opening government that their life is actually that bad, then let them make the choice themselves to get off the dialysis. If their life is actually that bad, I think we have to leave the choice to them rather than some random bureaucrat sitting in a Washington office, rather than some pre-med student who does these copying ideas. That's it though. What's the thing we get from the speech about the chilling effect? They say people are going to have no incentive to work on stage 4 renal dialysis, that scientists don't care because this is a terminal illness and it's seen as really hopeless. Okay, 3 responses. First off, scientists want to get prestige. I would hope that scientists have some sort of basic sense of dignity or some basic drive about them, other than just making money or getting along with their careers. I think people want to be recognized as good scientists, good research scientists who come up with developments. Secondly, however, keep in mind that there are often, I think there will be huge research grants for stuff related to this. No, thank you. But third and most, I think, basic, people don't like to see people suffering. I would hope that this is like a basic reason why you become a research scientist, why you eventually start doing stuff in medical technology. I think that's really screwed up if you think that people are purely in it for the money or even, purely in it for the prestige. That's it, though. What's this idea about the philosophy of health? I want to expand this very quickly. I think this idea has already come up. I think for the most part on opening government, what we've seen is that people, ought to be restored to their original condition, ought to be restored to a condition where they can enter the workforce. But I think pretty clearly, if you look at the way that healthcare systems actually operate, I don't think we make this kind of value calculus. I don't think that we deprive people of the right to healthcare based on sort of their current condition or their ability to re-enter the workforce. So what are some examples of this? In the United States, 2 examples. In California, there's a recent state law passed that mandates people to have health insurance. You can get it through a private carrier, or there's a government subsidy. This doesn't kick out if you start getting old. This doesn't kick out if you're not going to be able to re-enter the workforce. This doesn't kick out if you don't have legs or don't have arms or don't have any limbs at all, right? We keep getting this because we think it's unacceptable that people live in this state of suffering, as Angela pointed out. Another example, Vermont, right? A state where they have mandatory health care after Governor Dean's reforms there. They have not mandatory health care for everyone, but for children. So, we don't cut off health care for kids that have cancer or something. We don't cut off health care for kids that are born without 2 kidneys or stuff like that. And why is that? I don't think it's just purely because kids are cute. I think it's because we say that people have these basic human rights, that we don't want to see members of society suffer. Look also at England, where NHS also doesn't cut off for people who are terminally ill. It also doesn't cut off for old people who aren't entering the place. The same is true for Germany with the Krankenkasse there. Same thing, it doesn't cut off. So I think, looking at this, all this overwhelming amount of evidence, it seems to suggest to me that the purpose of healthcare and the assumption is that our undergraduate healthcare systems aren't about people returning to society, rather some basic thinking that I think opening up has fundamentally missed.
I thank the gentleman for his remarks, and I invite Kathleen to begin the case for Hobart and William Smith.
Okay, so of course outside government we don't like to see people suffer. We've been given a really hard position to take, but we think that it's important since we do live with limited resources, whether they actually be like the ingredients in medical technologies, doctors, money. These are all scarce resources, and this is just the real world situation that we live in. Like in utopia, sure, we'd love to have as many people as possible and as many like experimental drugs and treatments as they want and keep them alive as they possibly want, but unfortunately we just can't do that. We don't have the means, and there's no way we can have the means to do this, so we need to take the next best alternative, and outside government, we give you that next best alternative. I think that what we've been facing with so far is a really narrow ground. I think that opening opposition has challenged this, saying that we're not like totally in the spirit of the resolution, and that we're really only dealing with like money and stage 4 renal dialysis. But Jill and I are going to show you, while we're going to talk specifically about Medicaid in our analysis, we're going to show you through examples how this applies broadly to pretty much all aspects of medicine in a variety of different scenarios. So let's look at what we've gotten so far from the first government team. We've gotten a lot of specific analysis about stage 4 renal dialysis. We've gotten a lot of good background about Medicare. Now Jill and I want to bring this more into the context of like why we should do this now, why this is a specific duty that we have as a state, and why this applies to all areas of medicine, or most areas of medicine. So that said, I'm going to be speaking to you about better alternatives that we have, and then I'm going to be speaking to you about the expense of this and how it's like the duty of the state to allocate resources wisely. So let's first talk about better alternatives. We want to encourage on closing government prevention, not cure for diseases. What we're going to go by the old motto, a pound of prevention, or an ounce of prevention is worth a pound of cure. And we think that there's much better ways that we can deal with these problems that our society is facing than just like keeping people alive as long as they want on really scarce medical treatments or things that cost a lot of money. No, thanks, sir, I haven't said much yet. We think that since Medicaid is an absolute source of funding that, like opening opposition has said, gets underfunded continually year after year, this is especially pertinent to Medicaid. We think that it's really important that we encourage funding from the government to go to things like research instead, or that we like give treatment to people that are in early stages of diseases and have a better chance of thriving and surviving the operations. We want to use an example of organ donation here. Organ donation is a really expensive treatment. It's prohibitively expensive. There's really scarce resources, and there's not just like fields of organs that we can pluck from. We have a much better success rate for people in early stages of diseases that have healthier bodies. Therefore, we should make sure that we give those organs to people that have the highest chances of success, rather than just those people that can like pay for it most. Or we think that it's really important that we make sure that that we use these resources wisely and make sure that we can continue having a productive society instead of having more people die because they can't get treatment early enough. I think that's really important. We also want to talk about hospice care, something that hasn't really been brought up so far in this round. Sure, we understand that people that are terminally ill have really sucky lives and they deserve to be, like, they have this right to life, they have this right to comfort. We want to give them that through hospice care. We want them to be able to learn the process of death and grieving alongside with their families, give them comfort, give them the painkillers and the things that they enjoy. We think that that's a really morally acceptable stance to take. We think that death is a fact of life, and that our American culture has sort of developed this notion that you can evade death as long as possible. You can look like you're 30 for as long as you want. And we think that we should teach people who are in situations like this instead to be comfortable with their death and to face it and to grieve along with their families and to be able to deal with this in a better way. Sure.
So it would seem to me that like actually staying alive is like more important than being comforted towards the fact that you're going to die. And yet you seem, actually prefer funding the latter when I think it'd be much more effective to fund the former.
No, what we're saying is that we think that it's better to give people hospice rather than kind of giving them this false notion that if they just keep getting all these treatments, they can stay alive as long as possible. We think that it's actually sort of demoralizing for these people, and it gives them a false sense of hope. And we don't think that's acceptable. We'd rather give them hospice and teach them that it's okay to die. They don't have to fear. Their families are going to be okay. We think that this is kind of an unusual stance to take and one that the opposition is going to kind of deride a lot, but we think that it's really important and that we need to have this mindset in our society. Now I want to talk about the duty of state, sort of this realpolitik argument that Jill's been bringing up in POIs. We need to do what's going to save the most lives. Like, sure, there's a duty, like, we shouldn't weigh the right of one person's right to live against one other person's. But when we're talking about one person's right to get an organ donation that could cost hundreds of thousands of dollars, or one person's right to get like dialysis, which opening governments made very clear is an expensive treatment, versus like hundreds of kids' rights to get a vaccination and to go have physicals every year so that they aren't sick and that they can have like their life expectancy and grow up to be productive members of society. We think at that point, then you have to make a decision, and we think that you should choose the lives of many over the lives of that one. We think that it's better to encourage research and prevention and do things like teach people how to prevent preventable forms of cancer, like stay out of the sun, use SPF sunscreen, than it is to use this money instead to treat people that may have gotten to terminally ill stages. We'd advocate hospice care for these people instead. I think this is especially important when we look at Medicaid, because a lot of the people that are on Medicaid are children with poor families whose parents can't provide them good medical care. Otherwise, they're the ones most at risk of ending up in like a worse health situation. And as we've been saying, prevention is much better than cure. It's much better for us to allocate these resources to prevent these kids from reaching a stage that they might need this sort of care for a terminal illness that thanks. Now let's get into some rebuttal. So what we hear from the second speaker on side opposition is that first he says something about we can get rich people off the Medicaid rules, which I just want to point out they already are. That's the point of the program. I'm not really sure why he said that. Then he had a bunch of analysis about self-caused illnesses and how things like obesity lead to diabetes and that's a fact of life. Exactly our point. We're seeing proliferation of these diseases in our society. We want to teach people more about prevention. He talks about how someone's right to life shouldn't be decided against someone else's. I've already talked about that. Furthermore, I think that we show in our society that we do accept that sometimes one person's life deserves treatment more than another's. We have triage rooms in almost every single ER. States like New York State have failed to pass programs like S-CHIP that would ensure that every single child gets medical care. I don't think that we hold like this, everyone has a right to like all kinds of medical care in our society. Otherwise, we already have like socialized medicine. I don't think they can make this claim. Then he talks about scientists working on experimental drugs and how they just don't want to see people suffer. I think that first of all, there's other means of developing experimental drugs. You can use like the strain of cells that make up a disease or something like this. You don't need to have the actual living people. We think that also, even though research scientists might not want to see people suffer and they're not out for it for monetary gain, unfortunately they don't test the prices for medication, and it's a really expensive process to develop research, so we don't think that's really a good point on their side either. Then he talks about this philosophy of healthcare, and that we think that you shouldn't have to be restored to your exact previous quality of life. And we say that no, but there is a minimum standard that we should bring people back to. For these reasons, we're proud to propose.
Thank the lady for her remarks, and now I call Andrew to the floor to begin the debate for her.
Very much, Mr. Speaker. Thank you, everybody, this round. So, evidently, we should only employ medicine when we can bring people back to a minimum quality of life, and not below that. Then we should just let them die. And also, apparently, we're not in utopia, and the purpose of medicine is to teach people how to grieve. I'm going to get into my rebuttal matter in a couple of minutes, but I'd like to begin with a substantial extension that hasn't really been touched on at all in this round. Something that's rather surprising, because the second part of the model I thought, well, gee, Medicaid is a pretty politicized program, so we're probably going to be talking a lot about the effects that this will have on public support. But we haven't really heard that, so I'm going to talk about it now. So, I raised the issue in a POI that the fact that Medicaid can't treat a lot of poor people, that there are lives that aren't being saved, seems to me to be more an argument to expand Medicaid than to shrink Medicaid, than to pay for fewer people's treatment, than to, or rather we should be expanding Medicaid and paying for more people's treatment. We should be funding Medicaid better so that we can save more people's lives, allow more people to live for longer and not make this sort of weird sort of scale of death decision that opening government advocates. We think that it's probably good for Medicaid to be able to afford to treat more people. We certainly don't think that it's fair to teach people how to treat. No, thank you to either of you. So what do we think the consequence of their policy will be? What do we think will happen when Medicaid gets up and says, you know what? These people who are being wheeled onto the floor of Congress every year, we're not going to prolong their lives anymore. Those people should be wheeled instead of into Congress, into hospices, so that they can die as quickly as possible, get them out of our minds, and their family members can learn as effectively as they can about grieving. We think that a lot of people are going to be upset when Medicaid takes this sort of stance. We think that a lot of people are going to be rather sad that Medicaid has suddenly shifted its policy goals to killing people instead of saving people's lives. Sure.
Okay, but Andrew, at the point at which you're going to be able to spend the money that you currently spend on dialysis in treating lots more poor people for other sorts of diseases, don't you think people would be happy and jolly and affable?
Not as affable as I am. And I frankly think that at the point at which we have a lot of money in Medicaid and we need more, let's keep doing what Medicaid already does and then add money so we can save the lives of those other sorts of poor people. We think that that will become less likely on their side of the house because political capital in support of Medicaid will decrease because people will see that Medicaid is making these sorts of bizarre scale-of-life choices and denying people that are currently providing care. We don't think that that's the kind of direction Medicaid ought to go if it wants to survive for very long as a federally funded program. People at the Make-A-Wish Foundation, the families and the friends of people who are terminally ill will be very upset, and political support for organized medicine like the AMA and for socialized medicine like Medicare and Medicaid, when those sorts of programs aren't accomplishing the objectives that people in society want to see them accomplish, will drastically decrease. And Medicaid may even be able to fund treatment for fewer people in the future because they've started down this extremely dangerous path of weighing certain people's lives against other people's lives. Well, these people are probably going to be in a lot of pain. They're already pretty old. Their kidneys don't work very well. They're not worth saving. These homeless people have schizophrenia. They're probably worth saving. The treatment success rate for schizophrenia is only about 1/3, and it's not a life-threatening illness to begin with, but their lives are probably worth more. We don't think that this sort of calculus is ever something that doctors ought to pursue. If any of you has ever heard of the Hippocratic Oath, you ought to be aware of the fact that the goal of medicine is to save as many lives as possible. Not to say, well, these people are worth saving and these people are not. The one thing that even comes close to being responsive to this principle is the idea of triage, but that's not really applicable, because in the case of an extreme emergency situation where you have like one doctor and 8 patients, and which one do I treat? The doctor can literally treat a patient and not the other 7. But with Medicaid, you can, I don't know, spend money on more people. You can increase the spending of Medicaid. The resources aren't as scarce as they would have you believe, and triage isn't actually analogous. We also hear the organ example. You can't tax people to get more organs, but you can tax people to get more funding. So again, not analogous. We hear from the first speaker of the second half of government that we're not in utopia and we have to make these sorts of choices. But what we tell you on our side of the house is that we're trying to get there. We want to approach utopia. We want to approach a society in which we have more equality of income, more equality of medical care, more sort of socialized medicine programs, programs that are able to treat more people more of the time so that fewer people have to die as early as they do. We think that those are the goals of Medicaid, those are the goals of medicine, and side government sure as hell does not serve any of those goals by treating fewer people more of the time. So by way of rebuttal, what do we hear? We hear again, we're not in utopia, but we're trying to be. We hear death is a fact of life, teach grief. This is too ludicrous for a response. We say, no thanks, you had your chance. We say, keep people alive. Dialysis isn't exactly giving people false hope. It's giving people more months to live with their families and to do the things that they want to do while they remain alive. We think that this is probably an admirable goal for government programs. We ought to pursue more of them. We would also tell you, don't force people to learn to face death earlier. Probably not the best goal of a government program tasked with saving people's lives. The interesting thing that we have heard some of from both halves of this bench is the idea that we have to weigh people's right to life. But I've already sort of responded to this by saying that we shouldn't be in the business of weighing some people's right to life versus other people's right to life. We should probably try to treat as many people as possible, maintain the programs that we have, and expand the other ones. And we shouldn't sort of, say that these people are allowed to live at the expense of these other people. We shouldn't put dollar values on sort of years of people's lives. We ought rather to, again, pursue sort of the expansion of Medicaid to the greatest extent possible. We think that that's probably good. Another thing that I find interesting about this round, something that I want to talk about a little bit, is the philosophical equivalence to other people who are also terminally ill. Because essentially what they tell you is that these people who have this sort of terminal illness and who have this sort of predictable time horizon on their lives, these people don't deserve to have their lives lengthened. But Medicaid can continue to provide care for people who have, I don't know, terminal cancer. We can continue to sort of allow those people to live longer. So they restricted their model to dialysis. And I think that was a little bit silly, because essentially what they're setting up for you is this very bizarre dichotomy, where people with a certain sort of time horizon on their lives don't deserve treatment anymore because their quality of life will probably be pretty bad. But these people in similar situations, people who have, I don't know, bone cancer and things like that, those people can still receive Medicaid funding. We think that that's a little bit silly. Julia's shaking her head that like her team provided the model, and it certainly didn't make this sort of distinction. I think that it's important to recognize that it's sort of silly for Medicaid to fund these people, but not these people. To say that these people's lives aren't worth saving because their quality of life would be low or because dialysis is extra expensive. Drawing these sorts of lines, again, is not a goal of government programs. We don't want to say that these people are worth saving, that these people are not. We want to save as many people as possible. We want to get toward utopia, toward equality of medical care, and toward helping more people live as long as possible more of the time. So for all of these reasons, we stand proudly in opposition.
I thank the gentleman for his remarks, and I now call Jillian to the floor to complete the presentation for the government side.
I tend to pride myself in being a very pragmatic person, and so I'm going to take this from a pragmatic point of view, which is what our side has really done all along. The last speech we just heard, he said something that really caught my attention over and over again. He said, we want to save as many people as possible. The goal of medicine is to save as many people as possible. He said this, I think, 5 times in what I was listening and tried to make check marks. And exactly how does their side save as many people as possible? That's my first challenge. Explain to me how your side saves as many people as possible. Because if you're going to play the numbers game, which is repeatedly what you said that is most important, our side wins hands down and debate. Additionally, I want to know where this money is coming from. And I'm going to challenge you that specifically because, as my partner got up here and told you, we said there's no fixed amount of money. He said, let's just tax more. Okay, let's see, why? Because people who say, oh, I'm going to tax more to fund the health of poor people, oh, guess what? They don't actually get elected. So guess what? We can't just tax more. This is a great solution, except it doesn't actually work. They've given you lots of ideology continually over and over again, but health is about pragmatics. That's why in developing countries, what we do is spend a lot of money to distribute things like condoms, instead of spending a lot of money to try to distribute things like treatment. We know that giving condoms is more important than giving treatment. While they're both important, no thank you, we realize that stopping the spread of AIDS should take precedent over helping those people who have already contracted it, because what happens is you're breaking the cycle. It's important to see that in the end, we need to play the numbers game, because that's what governments do. So I'm going to talk about 3 things. First, the job of the government. Second, the jobs of doctors and medicines. And third, what really saves lives. And I think that another failure on this team is to really understand debt and how debt operates. And I'm going to cover that as I talk. So first, you're laughing, but my parents have raised us, so like this is something I know. So first, the job of the government. And what the main job of the government is to balance all people's needs and rights against each other. We think the government does this through funding certain programs when they think they'll be more successful, regardless of the fact that some people may need funding than others. We think the government makes these life decisions every day when it allocates budgets, when it allocates this school program will get lunches, this school program will get books, this school program will get nothing. It's important to see that we make these decisions that affect people's lives over and over again. Additionally, we need to realize that this is zero-sum, that this is the kind of situation, where we can't just add more money, we can't just institute universal health care. If it was that simple, universal health care would exist in the States today. But guess what, it doesn't, and there are very good reasons for that. Go ahead.
Listen, if the public is so willing to have cuts to the Medicare system and the welfare state, how are you guys going to get this reallocation of funds after you cut Medicare funding to this one region?
No, what we're saying is, no, why not? I don't understand. Why would they reallocate funds? What they do is they say, Medicaid, you get X amount of dollars a year. Do what you will with it. We'd like you to do this. Medicaid then does what it wants with that money. If all of a sudden Medicaid has an extra, I don't know, $50 billion or something like that, they can do a lot of really good things with it. Like, I don't know, universal healthy lunches in every school, or give every child breakfast. Those are things that, although not directly involved in medicine, things like main care, which is a branch of healthcare, actually fund, because we realize that good health in young children is essentially important to things like brain development, long-term health. those things can be funded through state programs. Additionally, we can do things like give universal dental care to kids. We realize now that dental care is essential to having a healthy diet. Those things are important, and those are things we can do with this money. The next thing I want to talk about is the jobs of doctors and medicines. Because over and over again, they say medicine is about saving everybody and about prolonging life as far as possible. But we realize that this just isn't true because we realize that medicine is a limited field. Medicine has limited abilities. We gave you the example of triage. They said, yeah, only in emergencies. But that also works in the Army. Like, if you're a medical doctor and you have 8 morphine doses, you don't give it to someone who's dying because you want to comfort them. You give it to someone who can be medevaced out so that they'll survive the trip. That's a very different thing, and that's what we advocate on the side of the figure. Additionally, they laughed at our point about legitimizing death, but then they brought up Make-A-Wish, which is actually a hospice foundation and couples hospice care with the Make-A-Wish services. Kind of really bad to bring that up. Additionally, a lot of what we need to focus on is that death isn't inevitable, and that death is something we need to accept, and it's completely healthy to promote that. Most hospitals actually provide social workers for all people that are terminally ill to go through this process. It's something that we provide for free because we realize it is simply that important. So then the last thing I want to talk about, and I think this is really what the case comes down to, is what really saves lives. Because if you don't believe out anything else I've said today, if you don't buy any other word that comes out of my mouth, what you need to buy is that this is about saving lives. And I think he really highlighted that by repeating it over and over and over again in his speech. So how do we save lives? We save lives by allocating resources most efficiently, most effectively. We save lives through preventative techniques and preventative education. We save lives through early treatment. These are all things that can be expanded. We save lives through early testing. We can provide early testing programs for cancer for way more people if we're no longer running this program. That means we can catch cancer patients much sooner and save many more cancer patients than we could otherwise. You're always balancing one life against many lives. And guess what? As sad as it is to say, and as much as it sucks to stand up here and say it, what you need to go is toward those lives.
Okay, you realize that the Medicare funding that's withdrawn from here will probably go to deficit reduction, and not to like this random other program
Except that I totally disagree. I think that withdrawing that Medicare funding, after saying that they're pulling it out to be more efficient, would be suicide. What's a great way to get unelected? To say, listen, I advocate for this plan, I advocate for changing this, and then to letting the money slip away. We all want to do the best scenario possible. Just because they might disappear in the system doesn't mean it well, and I don't think it well, because most people who run Medicare are looking to improve the quality of life it provides, not let money slip through the cracks. At the end of the day, not only do they need to prove that they save more lives, but they need to prove that they can actually pay for the system. They can't do either, and I'm sorry that they chose that route.
I thank the lady for her remarks, and I now call on Diana to conclude the debate for Harvard and for all of us.
Thank you, Mr. Speaker, for calling me to the floor today. It's a true honor to be here. It's been a great debate. Mr. Speaker, we're all dying. So what is the actual point of medicine? Medicine doesn't return us to our original quality of lives, does not return us to the very day that we're born, but instead gives us the best possible quality of life that we can get at that time, regardless of what is efficient, regardless of who is rich and who is poor. So what have we heard in this debate today? The opening side of the graph basically tells us that dialysis, first of all, doesn't better lives, and secondly, doesn't further medical research. I think that both of these are very problematic in this realm, insofar as I think that some life is better than no life, and therefore dialysis does indeed better lives. But then secondly, just the fact that something doesn't further medical research doesn't mean that we should be denying those specific people actually medical care. What do we hear then from closing government? We hear that we ought to learn to grieve, we ought to learn to face death, and we ought to use preventative measures. We ought to spend more on, providing lunches and dental care than saving lives. I think that this is also rather problematic when we look at the point of Medicaid is actually, saving lives rather than providing lunches and dental care. So what have we heard today from the opposition side of the bench? Opening opposition gives us very good analysis about culpability, how we actually, how people still have the right to live regardless of, whether they have, kidney failure or whether they have cancer or any of these other types of diseases. Realize that a few months worth of living is still life, and therefore we should still have an equal amount of life to every person. But then what do we tell you in our extension? And this is something that never gets addressed by the the closing government side, which is rather sad because it actually tells us how on the opposition we do actually manage to save more lives. What Andrew tells you is that there are political consequences in actually shutting down this part of Medicaid and actually telling everyone who relies on dialysis we are no longer going to actually give you this kind of treatment. What kind of message are we actually sending, Mr. Speaker, when we have this sort of goal? Basically what happens is we're telling people, we're telling the entirety of the United States that we're going to weigh your right to life based on what kind of disease you have. And if you actually don't have, that much longer to live, we're not going to care about you as much. What are the political consequences to this? We will obviously see that support groups will go down because you're actually arbitrarily picking who deserves to live and who deserves to die. And therefore, because of this, we will see that actually this X amount of dollars that they continue to talk about on government will actually go down because the support decreases. Sure. Okay, but Diana, at the point at which Medicare already denies treatment to most terminally ill cancer patients, and we don't see cancer groups taking their support away from Medicare, why would this happen for dialysis patients when they're solely making it more efficient?
The point of actually cancer patients is a lot of these places still want to do research because Medicaid is actually not giving them any support. The problem here is, as you pointed out, the reason why we actually want to give people on dialysis this kind of treatment is because if you cut that off altogether, you won't actually have all these other support groups because they simply can't provide dialysis. That's something that Medicaid does directly, right? But moreover, we think that it's important to look at dialysis in particular because you're actually still extending these people's lives, right? We see that support groups will actually go down for Medicaid and actually funnel to different support groups who actually still want to support dialysis. They won't support Medicaid in particular because Medicaid isn't helping you whatsoever. So overall, what do we actually tell you in the debate today? We tell you that there is actually going to be a consequence of this policy when we say we're going to direct people to hospices, and we're actually going to say you can die as quickly as possible. This will help us because this is somehow more efficient. But the actual philosophy behind medical care altogether, the actual philosophy is that we want to help all people, right? The government side has never given us any example of why some people deserve to live more than others. And we actually do think if we manage to give everyone an equal chance at living, because we think that, this pool that they've told you, we don't actually see that people would rather die than be on dialysis. They say we give up 60% of our lives, but we still don't think people want to die. Because of this, we actually do think that this is important. Sure.
Yeah, people actually do choose to go out for dialysis, but that's not what I'm saying. What we're saying is that people, in a zero-sum game, oh shit, I've lost my train.
Right.
Continue.
Okay, so also when they say that some people choose to go off of dialysis, we let them do that. But we think that people who want to stay on dialysis in particular, that's who is important in this round, right? The people who are actually making the decision that I want to live, however grievously I might have to suffer, we still want to live. Why do we have to deny these people the right to live? The government, the opposition side has already talked about, we can actually cut back funds for the rich who can afford to pay for dialysis for themselves. We think that we can expand things that way. But the problem with actually cutting this off to the poor, the people who rely on Medicaid most, is that they have no other avenue of actually achieving this whatsoever, right? This is their only option. Turning to Medicaid is their only option. We can't cut that off because of all these political consequences, right? You're going to see support groups go down because the poor people who already have less access to medical, resources already, they're going to be even further cut back by this altogether. So what do we actually see? We see that we shouldn't look at, preventative measures because, for instance, what if someone actually does follow all these preventative measures and, still needs dialysis? We don't think that these are the actual things that Medicaid should look at. Medicaid should look at saving lives. How do we best save lives? By looking at all people's lives, trying to save all people's lives altogether, and in that way we can actually manage to retain the support of these people. We actually do think that the trend in America today is that more people want to have more, healthcare, etc., more money spent on healthcare, etc. We think that we can only continue this trend if we continue to promise to actually give this to all people. Sure, last one.
Okay, if you don't ever get any better when you have end-stage renal failure, how does continued dialysis treatment actually save your life?
They say that you can never increase the quality of life. As I told you in my intro, the point of medicine is not to improve your quality of life, right? The point of medicine is to retain the most quality of life as possible. When you look at operations, you will never go to the same stage as you were after having an operation as you did when your organ was healthy. But the problem is that this isn't something a reason for us to actually cut this off altogether, right? We actually do think that some life is better than no life, and in that instance, we are still bettering lives. We still don't actually see how the government holds any water for this. So, in summation, what have we told you? We told you that the goal should be expanded Medicaid, and we can only do this if we continue to remember that everyone does have the right to life.
just as much of a right as people with other diseases, etc. We stand strongly in opposition. Thank you.
I invite all the speakers to cross the floor.
Do you mind if we go outside for a discussion because it's really
Yeah,
freezing
I know.
in here.
Let's let them clear out the
Yeah,
area.
yeah.
Thank you. Would you like to see the time?
Thank you.
Right, okay. God, I am freezing.
Yeah, why don't you go outside? I'm with you.